Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, a faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus, and I'm a family physician with Gateway Family Health Clinic in Moose Lake. I am your host for our program tonight on upper GI problems. The success of Doctors on Call is very, very dependent on you, the viewer. So please call in your questions tonight or email them to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Robert Erickson, a gastroenterologist with Essentia Health, Dr. Victoria Herron, a family medicine physician with CMH Rader Clinic in Cloquet, and Dr. Brad Irwin, a gastroenterologist with St. Luke's Gastroenterology Associates. Our medical students answering the phones tonight are Barrett Bukowick from Warroad, Minnesota, Nika Freeberg from Katumbi, Tanzania, and Tommy Gentle from Baudette, Minnesota. And now on to tonight's program on upper GI problems. I think we'd like to start out just trying to define the territory a little bit. Dr. Herron, what do we mean by upper GI?
Upper GI generally refers to your upper GI tract. That's the part of you that goes from the back of your throat down to about the bottom of your stomach and the first part of your upper intestine. It includes your esophagus, your stomach, the first part of your upper intestine, your duodenum, and some people will throw in the gallbladder as well in that territory.
So we start out in the mouth, or the back of the mouth. So let's talk a little bit about esophagus. Dr. Irwin, can you tell us a little bit about the esophagus, what it does and what we should think about?
Yeah, the esophagus it's a muscular tube. Its main job is to transport food that we've swallowed. Once food enters the upper esophagus, it's basically propelled down towards the stomach. That's its main function, really. It's comprised of a mucosa, that's the inner layer, and then it has a muscular layer. And the interesting thing about the esophagus, it's innervated with a combination of skeletal as well as smooth muscle, but the lion's share of the function's involuntary, meaning that once the food is down into the esophagus, you have no control of that propulsion. But that's what it does.
Dr. Erickson, maybe just to finish off the upper GI part, talk about the stomach a little bit.
So the stomach is a receptor from the esophagus, and it acts to grind the food. So you eat a steak, and it's a big piece of meat, and it has to grind it into smaller pieces to introduce it into the small intestine to be able to digest that further to absorb it. It also makes acid. It's involved in B12 absorption. So there's more to it than just being a sac and a grinder. It has other physiologic functions.
Victoria, I know you love this subject. What is GERD?
GERD. GERD is the problem where you have acid, which normally lives in the stomach, that migrates up the esophagus and causes problems. It can happen for a variety of reasons. Some people have it more than others. It can cause a variety of symptoms. Some people get that really bad heartburn in their chest. Other people can just get a cough. That acid reflux can be the cause of a chronic cough. It can be really annoying, especially if people eat close to bedtime and then lay down. They can get that heartburn that can keep them up at night, or a cough at night. It can be worse with certain foods. It can be detrimental to the lining of the esophagus. Normally your esophagus has a nice, smooth lining, but if it gets saturated in acid, it can eat away at the lining, resulting in ulcerations and possibly precancerous or even cancerous changes. That chronic acid reflux can do bad things, but it can be difficult to pin down because the intensity of the symptoms doesn't always relate to the intensity of the acid reflux.
Very good, thank you. Brad, you look down a lot of these, both of you guys, you look down quite a bit. What are some of the diseases, the esophagus is kind of a muscular tube. So we have GERD. Are there other things that happen in the esophagus that we should think about?
Yeah, in the range of diseases is quite broad. Dr. Heron mentioned, acid reflux. That's probably one of the most common things we see. Unfortunately, we can get cancer in the esophagus, and that can kind of come in different forms as well. There are infiltrating diseases that can affect the esophagus and then the motility of the esophagus. If you have severe reflux, you can then develop the ulcers that Dr. Heron mentioned and have bleeding from that. Manifestations of chronic liver disease can be seen in the esophagus in the form of varices. So there's quite a broad variety of things that we can see or find when we do upper endoscopy and then have to manage.
Bob, in the last year or so, maybe it's 2 years, I've seen a lot on eosinophilic esophagitis. And all of a sudden, it's a new player on the market or in front of us. What is that? What do we do for it?
Well, it's almost like asthma of the esophagus, is what I mentioned to the patients. It's the esophagus mucosa reacting to antigens in our food, in our diet. Often it's wheat, milk products, seafood, and eggs that patients are allergic to. The lining of the esophagus actually gets infiltrated with allergic type cells called eosinophils. And when that occurs, there's chronic inflammation and it can cause narrowing and stenosis. So the common scenario is and it's often in younger males, it's a 32-year-old male with intermittent problem swallowing, and then he eats some venison. It's certainly deer hunting season, and Dr. Irwin or I need to go out and take the venison out of the esophagus, when it's stuck. And that's sometimes the manifestation. There are medications that treat it to reduce that inflammation.
So, Brad, what do you do for it?
It depends. There's a couple of approaches with eosinophilic esophagitis. You can start simply by placing people on PPIs or acid reducers. So there's a subset that will respond to that. In other words, their swallowing will improve just with a PPI.
So a PPI is like omeprazole?
Like omeprazole,
okay.
Exactly. Then, as Bob mentioned, this is kind of an allergy of the esophagus to a food antigen. So the next logical step is do elimination diets, picking the common foods that trigger EOE and eliminating from your diet for a while and see if it responds to that. Next step would be, which I generally practice if I need to, I'll start adding steroids. Steroids in a slurry, typically something like budesonide mixed with a thick liquid, or make it into a slurry and swallow it. The old days we did inhalers and have people swallow them.
Treating asthma, right?
Like you're treating asthma of the esophagus. And that can be a challenge for folks because you try to swallow that gas, a lot of it comes out your nose and doesn't really get down there. So, and there's a couple newer medicines out now that gained acceptance or approval for this as well.
Bob, I'm going to pull you back to the stomach a little bit. Tell us about ulcer so that we can kind of pull some of the questions together.
Oh, sure. So ulcer is a defect in the lining of the stomach. So you see a canker sore in your mouth, that's what ulcers look like in your stomach. They're in the stomach or right after the stomach, and we'll call it a duodenal bulb. And it causes ulcers, number one, taking agents such as Motrin or Naproxen, what we call NSAIDs. But H. pylori has been determined to be a cause of ulcer, and it's probably one of the more significant advancements in medicine is the detection of H. pylori and treating that. In the past, people used to get surgeries, half their stomach taken out for what was an infectious disease. So since that's been discovered, we can treat this bacteria with antibiotics to reduce the need for surgeries and complications from ulcers.
Can you give us a real short story of how that was determined?
Marshall and Warren, so one was a pathologist, I can't remember what the other one was, but one actually drank a slurry of H. pylori and had an endoscopy done and saw the infection. So they satisfied Koch's postulate, which is proving that a bacteria can cause a disease. This bacteria had been seen in the early 1900s, but as a lot of things are recycled ideas, and then they took off with it then. A lot of people didn't want to believe it. This was in the early 90s. But he won the Nobel Peace Prize for that, Warren did.
Yep, he did.
Mm-hmm.
How do you treat that, Victoria? Or should we let these guys talk about treatment?
Once you've determined that somebody does have H. pylori, and they can do it on biopsy, if they're looking down into your stomach, take biopsies of ulcers to make sure they're not cancer, because some ulcers are cancer, some are not. Really hope yours is not. If they do find the H. pylori bacteria there, that's one way to diagnose it. You can also diagnose it with a breath test, because the bacteria are active, they're metabolizing, and if you can put a certain radioisotope, very safe for you, but you can measure it into the stomach and then measure what comes back out, you can prove that you have a bacteria down there. You can also do, it comes out the bottom end as well, stool samples to prove that you have H. pylori. There is a blood test, but the blood test is more useful to prove you don't have it, because once it's positive, it's positive. That means you
Forever.
Forever. So that's how you can prove that you have it.
Discussion beyond that?
No, she gave a very, very
Yeah,
good.
that was great.
Yep.
So the other place that we're circling around a little bit is the hiatus hernia now. So Brad, hiatus hernia.
Really nothing more than a portion of the stomach rising up above the diaphragm. And when that occurs, a couple things happen. The natural barrier to reflux is the lower esophageal sphincter and the diaphragm. And in the normal situation, these would line up and prevent acid reflux. If you have a common sliding hiatal hernia, that simply means that part of the stomach rises above the diaphragm. It kind of pushes up, and the barrier to reflux isn't as robust as it used to be.
So surgery for this?
The large majority of people do not need surgery for their hiatal hernias, and most people, if they've been told they have a hiatal hernia, they won't forget it. But most hiatal hernias are asymptomatic. But if you do have a hiatal hernia and reflux, the reflux is worse. But there are surgeries of people who have a lot of regurgitation. There are surgeries where you can pull the hernia down and perform a wrap of the stomach around there to repair it.
So your family doc, Victoria, what would you have me do without all of for a hiatus hernia?
For a hiatal,
Or maybe even for GERD.
and they're related. A lot of people with hiatal hernias do have the GERD. Weight loss can help. Not filling your stomach too full will help. Not laying down right after eating will help. There are certain foods that actually make reflux worse. And unfortunately, there are foods that people like a lot, and we eat a lot of. Tomato, onion, chocolate, peppermint. Caffeine makes things worse. Alcohol makes things worse. You can not eat a lot of the foods that make reflux worse. And if you watch yourself and don't overeat and don't lay down right after eating, you can make life a lot more pleasant.
And smaller meals probably.
That's the not overeating.
Does it help to spread your meals out over the day too, a little bit?
Yes.
I used to tell everybody, elevate the head of the bed.
Mm-hmm.
Is that still something that we do?
Yeah.
Gravity's cheap.
Yes, it is.
Yes, it is.
Yep. If you can get a bed that you can do that with.
So that brings us around to omeprazole. Is that a safe drug? You know, so I'm really old. When I was in medical school, we were taught, was it BOP for the treatment of ulcers? Bleeding, obstruction, pain, and perforation. That was the reasons. And all we heard about was surgery. And then Tagamet came along.
Yep.
But you can only use that for 3 weeks.
Mm-hmm.
And then we've gone on to where we are today. So tell me about omeprazole. Can we take that forever, or what's the story? And who wants to grab that one?
Well, it's a real interesting story. When we came out in training,
Right.
we could only use it for 2 months because it supposedly caused a carcinoid tumor in a rat. But it's been the only medication I've seen go from a black box warning to over-the-counter use. So over this 25-year period of time, there was a lot of omeprazole and other PPIs we call Prevacid is another one, Protonix is another one. There's 5 of them. And what they do is they block the acid pump. So you need to take it 30 minutes before you eat, so this pump is blocked. And then when you eat, it tries to stimulate the acid, so the acid can't come out if it's blocked. So that's what supposedly causes these bumps and these carcinoid tumors in the rats, but hasn't been proven to be the case. Now, since then, there's a lot of associations that have developed. Osteoporosis, chronic kidney disease, They even attributed dementia and early death to omeprazole. Now they just dispelled the early death issue, but all those are really associations. There's maybe two of them, infections of the GI tract and osteoporosis. Maybe are cause and effect.
Yeah.
But they're very effective medications, and if patients need that for their heartburn, it's really a risk-benefit analysis. And if their life is better on the medication, then it's worth taking it.
So I'll channel Ben Owens a little bit because we talked about Ben earlier, but Ben would say something to the effect of, you got to make a decision. Is the medicine worth? Do you really need that medicine, and how do you handle the risks? How do you do that, doctor? He'd probably look at one of the specialists, not at Victoria. So Brad, how do we make that decision?
Well, I think Bob did a great job explaining the safety of omeprazole. It's probably one of the most studied drugs ever developed, and there's been millions and millions of prescriptions for this drug for a long time. With that said, most people don't want to take a pill if they don't have to, and I'd rather not give them a prescription if they don't need it. So, typically in a case of just heartburn, we would probably use it temporarily. In our cases of Barrett's esophagus, the recommendation is still to use it indefinitely.
Indefinitely, yes.
Yeah.
So, Victoria, are there some non-pharmacologic ways to treat heartburn?
Kind of a lot of what we talked about.
I think you
for
pretty
the
much
GERD.
laid that out,
Yeah.
didn't you?
I did want to mention one thing about taking the omeprazole for a bit and then going off of it. It's the rebound acid that you can get if you've been on it for a while and then stop it. If you've been suppressing the acid pumps for a while and then stop suppressing, you can get kind of a rebound acid upswing for a bit. So some people stop it and go, oh my goodness, my heartburn is horrible. But if you give it a week or two, that actually will settle down. So if you use, say, Pepsid, if you take some Tums, if you really watch your diet and give it a little bit, you may get over that rebound acid.
That's really good advice. I agree.
One thing to add to that is it's one of the shared decision makings that patients need to make with their physicians, their primary physicians and their gastroenterologists. Have a conversation about these potential side effects, and the goal is to minimize medications. But if you need a medication, again, it's a risk-benefit analysis.
Yeah.
And I just want to reiterate, in all my years of working with the GI people, there's always been a good relationship back and forth and sharing as to how we would handle patients. And we really appreciate that from our specialty people. We've already kind of touched on this, but how much of a role does gravity play in the upper GI? It's an interesting question.
For a reduction of heartburn, you mean, or?
I'll just leave it open. That's the question.
Well, the interesting part about it is I've seen in a particular, it was a band where the guy would do a headstand and swallow water. So so it can be done. You can swallow water anti-reflux, but that doesn't happen very often. And part of, I guess gravity would be related to keeping acid down, to emptying the stomach.
Probably best to sit up when you're eating.
It is.
Yeah.
Yes.
I think that would be
You don't want to do a headstand.
That's right. How does dysphagia mimic COPD symptoms, and is it related to interthoracic stomachs? So I suspect we're talking hiatus hernia again with that. So dysphagia or difficulty swallowing, does that mimic COPD? I'm foggy on that one. I don't think it does, but you're all shaking your heads.
Yeah, I'm trying to reach for that, Bob. I don't know.
Yeah, maybe they see you can feel a fullness in your chest from COPD.
Yeah.
Dysphagia, I mean, if you swallow and something gets stuck, you actually usually have hypersalivation.
Yeah.
So maybe that's one way of telling the two apart.
What causes increased phlegm and coughing from a GI standpoint?
Not
I
much
suppose heart
I was going to say, well,
reflux,
if
maybe?
you're coughing up phlegm, it's probably not from your stomach. It's more your chest or your chronic bronchitis or whatnot. But I mean, and Victoria mentioned this, Bob mentioned this, you can have regurgitation of stomach fluid, and that might be what they're referring to.
Yeah.
Yeah.
didn't touch on the fact that if you have bad enough acid reflux, you can actually get enough inflammation in your esophagus that some scar tissue will form, and it can form like a ring that's actually blocks food from going down and can obstruct food to the point that you are throwing up your food, and you will be coughing up and regurgitating your food and saliva and stuff because you have a ring of scar tissue preventing things from going down. And that requires the services of one of our specialists to go down there and get the blockages out and stretch out the ring.
There is one thing, is that sometimes people or patients have a hard time telling sinus drainage from reflux, especially when they're having problems swallowing right here at the sternal notch. So that's one issue too, where maybe it's coming from sinuses.
Well, I was always taught that a quart a day goes down the back of your throat from the top. So I don't know what you guys, that's where I come from, that's what I was told.
Well, it's liters of intestinal secretion per day, you know, so.
We had an email come in, a patient with intense stomach pains in the middle of the night, lasted about an hour. She was ready to, I'm assuming she, but it might have been he, was ready to call an ambulance, but decided to wait and went back to sleep. Didn't feel well for the next couple of days. Recently had a CBC and her doctor said she was fine. Could this be gallbladder? Should she have further testing? Still some dull pain. Thoughts?
It can be a variety of things.
Family doc, is
I
that
think
something
that-
you want to jump in? Let's just turn.
Well, yes.
Let's turn.
That sounds like a good thing. Did she actually go see the doctor? Where is the pain? If it's still there, I guess there's a lot of information
That's missing.
that's missing in order to make a good call on that one.
And no physical.
Yeah, a little non-specific.
But if it persists, you know, persistent pain's
Yep.
always
Yep.
always an
Yep.
issue.
Right.
Should
Yes.
be evaluated.
And we don't know age. We don't know a lot of things on this one.
Yeah, but he's right. If it's persisting, a little bit more workup would probably be in order.
Why doesn't the stomach valve open to pass food into the small intestine? I'm not sure where this comes from. I think generally it does, but I know that diabetics and others, sometimes there's delay in emptying.
Sure.
Thoughts, Brad, you want to jump in?
I'm assuming they're talking about the pylorus, which
Yes,
is
that's what
nothing
I'm
more
thinking.
than basically the muscle that opens and closes and allows food to transit into the small bowel. A lot of reasons you can have dysfunction there. You can have ulcers form, and that can form scar tissue and stricturing in the pylorus. There is pyloric stenosis in infants that needs surgery to correct. You can have, you mentioned essentially gastroparesis, which is delayed gastric emptying in diabetics and people with other neuropathies. And there's a subset that are idiopathic as well, which simply means that there's a delay in stomach emptying as well. So yeah, it could range the gamut from malignancies to ulcers, et cetera, in other folks.
One of the questions that also comes up is taking higher doses of PPIs. Does that have any effect on possibly catching COVID? Does that make you more susceptible? And I honestly have no idea myself. And you guys don't either.
I don't think we have any
To the best
information
of my
on that.
knowledge, it does not,
It does
but that's
not,
to the
yeah.
best of our knowledge.
I think it floated around there for a while early on in
Yeah.
the COVID outbreak. But
Yeah, but I don't think there was anything proven about it.
Right, right.
This is an interesting question. After 2 years of reflux, I'm having trouble swallowing. Is this serious? Yes, go get checked, correct?
Yes, go get
Any-
checked.
Yeah, we're probably in agreement on that. Is there any way to prevent, and we've talked about this, Barrett's esophagitis and reflux, hiatus hernia. Number one, I need to lose weight, right? So weight's a factor. And any other thoughts?
I think everything that
Everything we've said,
Vicky
we've
said,
covered
yeah,
it,
yeah.
okay. Is GERD seasonal?
Ooh, that's a good one.
That's a good
Yeah, it is a good
question.
one.
I know there's ulcers have said to be seasonal,
Mm-hmm.
Yeah.
but I suppose you could maybe think about foods being seasonal, and
The question is late fall and late spring.
that's related to ulcers more, I know.
Mm-hmm.
That's
don't know
true.
about GERD.
I've forgotten that. Yes, it is seasonal. Peppermint gels. Are they helpful for heartburn?
Generally not. They can be helpful for swallowing. They can actually precipitate more reflux.
Hiccups. What causes hiccups? Don't sit there silent.
It's a rhythmic contraction of the diaphragm. And, you know, as you know, sometimes it takes various measures to try to get that to stop. And
You got 15 or 20 seconds, so what would you do?
one thing you can do is hold your breath. And
Yeah.
I think I've heard that. But I don't know of a good reason. They've been around for a long time, and
Yeah.
I don't know for sure what causes them. Why does prednisone cause my severe hiccups was the question where it started out. So does prednisone do that or not?
Well, apparently for that person it
That
does.
person
It does, and that's a good answer. And with that, thank you so much. I want to thank our panelists, Dr. Robert Erickson, Dr. Victoria Heron, and Dr. Brad Irwin, and our medical student volunteers, Barrett Bukowick, Nika Fieberg, and Tommy Gentle. Next week, please join host Dina Claybow for a program on child and adolescent mental health, when her guests will include therapist Ann Meehan and psychotherapist Mary Morehouse. I want to thank you so much for watching us. Have a great night.